A very good evening to one and all present here. Today's topic of discussion is anatomy of eyelids, and the moderator for this presentation is Dr. NRS ma'am. Introduction: eyelids is also known as the blepharos, and these are the mobile tissue curtains which are placed in front of the eyes. And the main function of this eyelids is the protection, and it preserves the vision. Then it helps in formation of tear film. They contribute to the lacrimal pump mechanism and also evenly distributes the tear film over the anterior surface. Embryology. So eyelids, the upper eyelids are usually derived from the mesenchymal proliferation of the frontonasal process, and the lower eyelids are derived from the mesenchymal proliferation of the maxillary process. There are three stages in the development of the eyelids. At first, you have a fusion of the eyelids, which happens between 8 to 10 weeks. And then you have the development of the lid structures, that is levator palpebrae muscle. This happens between 3 to 4 months. And then eyelid disjunction occurs between 5 to 6 months. There are three factors which contribute to the eyelid dysfunction. That is keratinization of the lid margins occurs. Then there is contraction of the inferior lid retractors, and there is secretion of sebum. All these three factors together contribute to the eyelid disjunction. So if there is any defect with this development, it can lead on to certain congenital anomalies. Like with the eyelid fusion defect can lead on to coloboma of the eyelid. Defect with the LPS muscle formation leads on to congenital ptosis. And eyelid disjunction defects can lead on to uriblepharon. Uriblepharon is a horizontal lengthening of palpebral fissure occurs. Ankyloblepharon, there is incomplete separation of the lids, forming an adhesion between the upper lid and the lower lid. And then there is blepharophimosis, that is shortening of the palpebral fissure occurs. There is epicanthus inversus. There is an extra skin fold connecting the upper lid and the lower lid. And telecanthus is increased distance between the two medial canthi, and ptosis can occur.
Okay, can somebody tell me that when there is complete absence of the eyelids are not formed. Is there any syndrome that can be associated with that? Okay, so that is one. Another thing, go back, coloboma. When you see eyelid coloboma, it can be different types of colobomas. It might not always be like this. It could just be a small notch also which is there. Tell me a syndrome which is very classical and more like quite often seen, which has a dermoid, which has preauricular tags, and which could. Okay, very good. They may not always have a lid coloboma, but you have to look for the subtle notch which might exist. Okay, so yeah, and there's also something that is called as Tessier's clefts. Okay, Tessier's clefts basically are amniotic bands that they say that that is a hypothesis that amniotic bands they technically press over the face during the development age between the third to fourth month of gestation, and that can affect the entire face. There are different levels of Tessier's clefts from 0 to 16, but for your thing, mainly Tessier's 4, 5, 6 can also involve the lid. Okay, so that will be the eyelid, the face also. So you'll be seeing one band across.
Okay. Gross anatomy. The upper lid extends from the eyebrows to the superior border of the palpebral fissure, and the lower lid is from the inferior border of palpebral fissure and merges with the cheek. Position of eyelid. Upper lid usually covers about 1/6 of the cornea, that is about 1 to 2 millimeter below the superior corneoscleral limbus, and the lower limb just touches the cornea. Lid folds. The superior lid fold is formed from the tendon of the levator. This tendon of levator extends its fibers between the muscle bundles of the orbicularis and gets attached to that of skin. And the lower lid, that is formed from tendon of inferior rectus muscle. And in the lower lid, you have the nasojugal fold medially and the malar folds laterally. This marks the junction between the and the.
It is not the tendon actually, it's the levator aponeurosis that we call.
Yes.
Okay, and it's not the tendon of inferior rectus muscle. What is it that forms the inferior lid fold? I'm sorry, I missed that. Okay, while checking the slides. Yeah. What forms the inferior lid crease or the thing? So it's the capsulo-palpebral fascia. Okay.
Okay. And the nasojugal fold medially and the malar fold laterally, they form the junction between the lid skin and the denser tissues of the cheek. So this is going to limit the spread of any blood or fluids from the eyelids into the cheeks. Medial canthus contains the caruncle and the plica semilunaris. And the lateral canthus, this is usually situated 5 to 7 millimeter from the lateral orbital margin. And with the eyes wide open, they form a 60-degree angle. And in a normal way, they form a 30 to 40-degree angle.
So 1 minute.
Yes.
Now, what is the important thing here that you should remember about the lateral canthus and medial canthus while doing a reconstruction? So your lateral canthal tendon is always 1 to 2 millimeters above the medial canthal tendon, unless you have any variation, which she will be talking about also.
Yes.
Right? Besides that, okay, quick question. She'll be talking about it, but I want to know how many limbs does the lateral canthal tendon have? How many eyelids are there? There'll be 2 limbs, no? 2 crusks. Okay, and where does it insert into? Whitnall's tubercle, correct. So that is on the inner surface, 1 to 2 millimeters up and above and inside the lateral orbital rim. Now, fast tell me about the medial canthus. So how many limbs does the medial canthal tendon have? 3. Excellent. What are the limbs? Anterior, posterior, superior. Okay. And what is the importance of the anterior limb? Applied anatomy. Why is anterior limb important? Somebody said identification of. Okay, so identification of the lacrimal sac is important, and you need to dissect and disinsert the anterior limb if you want to do a DCT, that is dacrocystectomy. But you do not need to disinsert the anterior limb if you're doing a DCR. Okay. Now the angle is basically formed by the posterior and the superior limb of the medial canthus. Please continue.
As said, lateral canthus is usually higher than that of medial canthus, but with certain malpositions, when the lateral canthus is elevated more than the medial canthus, it forms a mongoloid slant. And if the lateral canthus is lower than the medial canthus, it forms an anti-mongoloid slant. Mongoloid slant can be seen in conditions like Down syndrome, whereas anti-mongoloid can be seen in Treacher-Collins syndromes. Eyelashes, they are usually arranged in 2 to 3 rows, and the upper eyelid contains about 100 to 150 lashes, which is directed forward, upwards, and backwards. And the lower eyelid is about 50 to 75 number. They are directed forwards, downwards, and backwards.
Okay, so now about eyelashes, she's already mentioned, right? So now tell me 2 anomalies that can be associated with the eyelashes. Excellent. So what is dystichiasis? Very good. And that is generally congenital or acquired?
Both.
Okay, excellent. And what is trichiasis? So you have primary or you have secondary, right? Secondary could be because of any ongoing inflammation or ocular surface conditions. So you need to know that there's a difference between trichiatic lashes and dystichiasis. Okay.
Palpebral fissure, this is an elliptical space between the upper lid and the lower lid. At birth, the horizontal distance is 18 to 21 mm and vertically it's 8 mm. Whereas in adults, it's about horizontally 28 to 30 mm and vertically it forms about 9 to 11 mm. Eyelid margins, they form 2 parts and this is divided by the lacrimal papillae into medial lacrimal portion and lateral ciliary portion. And lateral ciliary portion consists of the anterior round border and the posterior sharp border as seen in this image. And in between you have the gray line. And this gray line exactly divides the eyelid into 2 lamella, anterior lamella and the posterior lamella. Anterior lamella will contain the skin and orbicularis oculi. Posterior lamella will contain the tarsus and the conjunctiva.
Tell me the importance of gray line.
Bloodless disease.
Then it's avascular zone. So you generally take an incision there. You even take your lid traction sutures in that plane. And like she correctly said, it divides the anterior and the posterior lamella. Anything else I'm missing out?
It can cause minimal scar tissue formation along this line.
Correct. Okay.
And this gray line represents the pretarsal orbicularis oculi part and a structure of the eyelid. So from outside to inside has the skin, subcutaneous fat, skin, subcutaneous tissue. Then you have the muscle of protraction, that is orbicularis, and then you have the orbital septum and orbital fat, then a muscle of retractions, that is levator muscles, then tarsus, and then you have the conjunctiva behind.
So where does your orbital septum and LPS go? You spoke about anterior lamella, which consists of the skin and orbicularis.
Okay.
You spoke about the posterior lamella, which consists of the tarsus and conjunctiva. So there is a third lamella, which is also called as a middle lamella, which is important for surgically, basically for us, which consists of the orbital septum and which consists of the LPS muscle. Okay, we'll talk about the applied anatomy while you're discussing the other things, right?
Skin. The epidermis layer is made up of 6 to 7 layers of the stratified squamous epithelium, and the basal layer will contain the sebaceous glands and eccrine sweat glands. And the dermis is made of connective tissues with blood vessels, lymphatics, and the nerves. And this is the thinnest skin. And subcutaneous tissues, there are a layer of loose areola
Thinnest skin amongst what? Thinnest skin amongst the rest of the body, right?
of the body.
Ah.
Subcutaneous tissue, there are a layer of loose areolar tissue, and they are completely devoid of fat. But this layer is absent in regions like ciliary margin, lid folds, and at the medial and the lateral angles where the skin will be attached to the underlying ligaments. And hence, the blood and the fluid can get easily collected here and gets distended.
So now tell me about the skin. How do you measure anterior lamella in the upper eyelid? And how much should be the minimum anterior lamella in the upper eyelid?
Hello. And we measure it from the lid margin to the brow, and it's like 25 to 30.
In up gaze, in primary gaze, and abduction, adduction.
Down gaze,
Correct. Yeah.
25 to.
So basically, you measure with asking the patient to look down, okay, from the last brow hair to the lid margin. Okay, you have to measure central, medial, and lateral, and that will tell your anterior lamella in the upper eyelid. Okay, a minimum of 20 millimeters anterior lamella is mandatory. Anything less than that will cause what? Contracture of anterior lamella causes what? What eyelid malposition would it cause? Yes, thank you. What kind of ectropion would it cause? Yes, so shortening of the anterior lamella will cause cicatricial kind of an ectropion. Now for the lower eyelid, you generally ask the patient to look up and open their mouth. So that kind of stretches the anterior lamella in the lower lid. And if the lid is not well opposed to the globe, that means there's a lower lid shortening of the anterior lamella and cicatricial ectropion in the lower lid. Okay, so that is about your anterior lamella malposition.
Orbicularis oculi. This is divided into the orbital part and the palpebral part. The palpebral part will be further divided into pre-tarsal and the preseptal portion. First, orbital part of the orbicularis. They take up its origin from the medial palpebral ligament and from the adjacent bones, like frontal process of the maxilla, maxillary process of the frontal bone, from the upper and the lower orbital margins. And the fibers are going to sweep superiorly and inferiorly, and they get inserted along the lateral palpebral raphe. And the upper medial fibers are also called as the musculus superciliaris, and inferior medial and lateral fibers are also known as the musculus malaris.
What is another name for musculus superciliaris? What is another name for musculus malaris? Okay, fine, continue.
The function is forced closure of eyelids, and palpebral part of orbicularis, they are divided into pretarsal and the preseptal portion. Pretarsal portion, they have two heads, the superficial head and the deep head. Superficial head is originating from the medial palpebral ligament, and the deep head takes origin from the posterior lacrimal crest and the lacrimal fascia. This deep head of the pretarsal portion gets fused around the common canaliculus, and this is also called as the pars lacrimalis, otherwise known as the Horner's muscle. And the lateral extensions of this pretarsal orbicularis forms a muscle of Riolan, otherwise called as the pars ciliaris, which passes along the ciliary follicles.
Okay, so what's the clinical application or applied anatomy of knowing pretarsal orbicularis or Preceptal orbicularis. So, what exactly happens in elderly patients?
There is overriding of the preceptal over the pretarsal, giving that puffy look and the prolapse of the fat.
Correct. So, what will that cause if there's an overriding of the preceptal over the pretarsals? It will cause an entropion.
Yeah.
Okay, so that is one of the reasons of senile entropion or involutional entropion. So you should know applied anatomy because that is where you're going to target. Now, if you want to correct it temporarily, you would like to give Botox to that muscle, paralyze it so that it will temporarily correct the entropion in that area, right? So that is the importance.
And the nerve supply is the temporal and zygomatic branches of the facial nerve. And the function, they are responsible for gentle closure of the eyelids during blinking, sleep, and voluntary closure. And the antagonist of the orbital portion is the frontal belly of occipitofrontalis, and that of palpebral portion is levator palpebrae superioris. So paralysis of orbicularis oculi muscle can lead on to lag of thalmos, ectropion, and epiphora can occur.
So go back. Okay, now tell me what is the cause of epiphora in this condition? One is probably the punctal ectropion that is there because of laxity and because of paralysis of the orbicularis. Very good. Then
That functional pump mechanism is not working because of
excellent. So which is the
weakness.
muscle that is involved in that? She just mentioned that, no?
Horner's muscle and
Excellent.
pointer.
So many of the patients who come to us with facial nerve paresis, please do not send them for syringing and say there is an NLD obstruction there. Do Rho plus, do syringing, check for lid laxity, check for the puncta, and one of the major causes of epiphora is lacrimal pump failure, right? So that is something that has to be rectified. How do you rectify that? Strengthen the muscle, look for laxity, and do a lid tightening procedure or correct and reposition the puncta and also correct the lag of thalamus.
Septum orbitale. This is a thin floating membrane of connective tissue present, and they take up their origin from the periosteum over the superior and the inferior orbital rims. And their attachments, peripherally, they are attached to the arcus marginalis, which is formed from the periorbita and becomes continuous with the periosteum of the orbital bones. And then laterally, they get attached to the orbital margin in front of the lateral palpebral ligament, and medially they go deep to the posterior lacrimal crest, and they get inserted behind the medial palpebral ligament, and in the upper eyelid they fuse with that of the levator aponeurosis, and in the lower lid they fuse with that of the capsulopalpebral fascia.
So, what is the applied anatomy of the orbital septum, Prithvi? How is orbital septum or identification of the orbital septum important for us during LPS? Okay, so one is that your pre-aponeurotic fat pad will prolapse once you open the orbital septum, and just below that is your LPS muscle. So one is for identification. Second, yes, so in cases of trauma, if you see through a lid laceration the fat is prolapsing, means your septum is breached. Okay. Third thing, you never ever close the orbital septum. Why do you not close the orbital septum?
Lag of thalamus.
Yes, you're right. So it basically causes retraction and lag of thalamus. If there is lag of thalamus, if the patient has poor bells, it will end up in corneal exposure and further corneal exposure keratopathy and deterioration of vision. Okay, so never suture the septum in a case of trauma. Directly you close the skin if it is superficial one. Okay, so I was telling you also about the middle lamella. Okay, you finish LPS, maybe we talk about that then.
Structures piercing the septum orbital includes lacrimal vessels and nerves, then supraorbital vessels and nerves, supratrochlear artery, infratrochlear nerve. Then there is anastomosing vein between the angular and ophthalmic veins, superior and inferior palpebral arteries, and aponeurosis of the LPS muscle, and also the expansion of the inferior rectus. Orbital fat pad. They lie posterior to the orbital septum and in front of the levator muscle. And upper lid consists of two fat pads, that is the medial and the central fat pad. Sometimes the lacrimal gland can also be mistaken for this fat pads. And the lower lid consists of three fat pads, medial, central, and the lateral. Of this, the central is of utmost importance because they lie directly behind the orbital septum and in front of the levator muscle. And the inferior oblique muscle usually runs between the medial fat pad and the central fat pad.
In the lower lid.
In the
There
lower
is no LPS in the upper lower lid, right? So if you tell
Yes,
lower
ma'am.
lid and upper lid.
Yes.
Okay. Kimi, tell me, how do you differentiate between the medial and the central fat pad in the lower lid? It's a little more pale, so it is easier to identify, okay, compared to the central. How do you differentiate in clinically? How do you differentiate between a fat prolapse or a lower lid lesion or something like that?
Ask the patient to look up.
Why?
So the fat will prolapse out when.
So why does the fat prolapse? Just now we mentioned, right, the importance of orbital septum, right? So if it is fat, the septum contracts, okay, and the fat prolapses more. So that means that that is a fat which is prolapsing there. Understood? And it could be, I mean, it's not any other lesion or something like that, generally. So that is the importance of clinical evaluation. Ask the patient to always look up. If it is becoming more prominent, that means it is generally fat. Also, other features like it is more compressible, it is soft, and all of that, other things you have to assess.
Muscles of retraction. Upper lid contain the LPS muscle and the molars muscle, and the lower lid has capsulopalpebral fascia and the inferior tarsal muscle. First, to the levator palpebrae superioris, they take up their origin from the undersurface of the lesser wing of sphenoid and up just above the annulus of the sin. And then it passes below the roof and just above the superior rectus muscle, and they widen anteriorly and descends vertically. So when it is approaching the septum, it is going to fan out into a white glistening sheet that forms a levator aponeurosis. So it is going to pass from horizontal to vertical direction. So this change in direction occurs at the level of the Whitnall's ligament, and this is also called as the check ligament of the LPS muscle. And this levator aponeurosis splits up into the medial horn and the lateral horn. Medial horn fuses with the medial canthal tendon, and the lateral horn is going to divide the lacrimal gland into orbital portion and the palpebral portion, and they get inserted along the lateral canthal tendon. And nerve supply is by.
I'll just stop you there. Sorry.
Yes, ma'am.
What is the clinical anatomy of what she just mentioned about the lateral horn of the LPS, the lacrimal gland? So, how is that important for us clinically? But when will you do a biopsy? Clinically, what do you see? When do you suspect that there is a lacrimal gland lesion? What are the clinical features that you'd probably see in a lacrimal gland lesion? Excellent. So, where will your abaxial proptosis be? In what direction? Very good. Besides that, anything else? That will happen only when the mass is really huge, right? And then there is a pressure effect. If it is an early stage, what else would you see? One of the classical features of any lacrimal gland lesions. And that is why this is important. What does LPS do? If any trauma happens to LPS, kya hota hai? Ptosis, right? Now, if there is only there, I mean, laterally, if there's a pressure there on the LPS muscle, you'll get S-shaped ptosis. Correct? So that is one of the clinical or applied anatomies of for this. So when you're even doing a biopsy, you should make sure you don't damage the lateral horn of the LPS muscle. Otherwise, you will actually induce a ptosis even after you do a biopsy or you do removal of the tumor. So this all must be counseled to the patients also, right? Please proceed.
Nerve supply of LPS is the superior division of oculomotor nerve, and the analog in the lower lid is the Lockwood ligament. And any disruption with this levator aponeurosis and LPS muscle can lead on to ptosis. And this is the superior transverse ligament of the Whitnall. And they are a thickened band of orbital fascia. They are formed by the condensation of the levator muscle with joined medially with that of the superior oblique muscle. And tissues superior to this ligament is the muscle, while inferior to this is the aponeurosis. And damage to this ligament is also going to cause the failure of LPS function.
Okay, so what is the clinical anatomy of Whitnall's ligament here? Is there anything that is of significance to us, Kim? Surgically, I'm saying. So that is like a cutoff for us when we're doing an LPS resection. Supramax LPS resection, we generally do not go and cross beyond Whitnall's. There's also a surgery which is called as Whitnall's sling, wherein they anchor, I mean, we operate till there, but okay, that's not of any much importance. But just remember, you don't cross Whitnall's, okay? That is at your level. Now, quickly, she's finished LPS. I'm going to pick one of you. Tell me what are the 5 attachments of the LPS muscle? I mean, LPS aponeurosis rather. Not superior lid fold, superior lid crease. I mean, lid crease, basically the skin. That's how it forms the lid crease. So that is very, very important, forming the lid crease. And that is one of the clinical applications or clinical signs which will tell you that there is an LPS aponeurosis if there is an asymmetry in the lid crease. Okay.
Then posterior fibers to superior conjunctival fornix, medial canthal tendon, lateral canthal tendon.
Excellent. Very good. Upper tarsus, and the most important. So that is important clinically because it goes and attaches onto the skin, and that is what is formed. That is what forms your lid crease. So when you're operating, if your lid crease is not symmetrical, if it is not well formed, even though you've lifted the lid, the symmetry or the aesthetic outcome will not be as good as you want. Okay. So wait, I have another question. Whom do I catch? Tell me, how do you differentiate between, what are the clinical signs when you differentiate between aponeurotic ptosis and congenital ptosis? Clinically.
Ma'am, lid crease, which will be absent in congenital and it will be high in the aponeurotic. Then
Okay.
levator palpebral function, lid retraction
Lid retraction.
in down gaze means
तो उसको क्या बोलते हैं?
lid lag,
Where do you see lid lag? Correct. Congenital or acquired?
congenital.
So you'll have a lid lag and down gaze, okay? And you have to ask the patient to follow your finger to assess for the lid lag. Whereas in aponeurotic ptosis, the lid will be more down when you ask the patient to look down. So these are the three, besides the other things, these are the three important signs. So lid crease is very important. That will help you differentiate between congenital and acquired ptosis also, okay?
So if there is any oculomotor nerve palsy, inactivation of the levator palpebrae occurs leading on to ptosis, and there is unopposed action of the superior oblique and the lateral rectus. So the eye will be positioned down and out, and there can be mydriasis.
This is not just LPS. Go back. How many divisions does the oculomotor nerve have?
Superior and inferior division.
Yes. So what happens if the superior division is affected, and what happens if both the divisions are affected? So if only superior division is affected, you'll have something that is called as a, what is
There'll
double?
be bilateral affection of the superior rectus, as in it has double innervation. So both the superior rectus.
What is double elevator palsy? Correct. So you'll have ptosis and you'll have elevation restriction. So in cases of ptosis, when you're looking at a patient with ptosis, it's very important to assess the extraocular motility also. Okay. And third nerve, in turn, like Arish correctly said, supplies the other muscles also. Right. So you need to assess for that also, whether it's a complete third nerve or it's a partial third nerve. Continue.
Muller's muscle, and they take up the origin from the undersurface of the levator muscle, and it causes about 2 to 3 millimeter lid elevation, and they are mainly supplied by the sympathetic fibers. And in case of Horner syndrome, when the sympathetic fibers are getting interrupted, and this will lead on to mild ptosis. And important surgical landmark for identifying the Muller's muscle is the peripheral arterial arcade, which will be situated between the LPS muscle and the Muller's muscle.
So
And
what is, go back. So what is the applied anatomy for Muller's, I mean, or rather clinical application of Muller's muscle? Is there any test that we do clinically in order to assess a surgery which is associated with Muller's muscle? What is the test? Yeah, Nikhil? Yes. So what happens in phenylephrine test? But how? Why would it retract? What is the supply of Muller's?
sympathetic stimulation.
Excellent. So this is an important test in case of mild ptosis. Okay, when you have about 1 to 2 millimeters of ptosis, your patients are very fussy. Okay, you can plan something that is called as conch mullerectomy. You can do phenylephrine test, which will contract the Muller's muscle and tell you how much elevation or improvement in ptosis you can get. Right. So that is also one test for mild ptosis. You can plan your surgical approach accordingly. Okay. What is another name for Muller's muscle? Where is it located?
Under the LPS muscle.
And from posteriorly, where is it located? Just above the tarsus. So it is also called as a superior tarsal muscle. Okay?
Okay.
Right. Next.
Inferior lid retractors, you have the capsulopalpebral fascia, and these are usually originating from the inferior rectus, and they splits up into two horns, and then they lower the lid, they are going to envelop the inferior oblique muscle, and they join together to form this Lockwood ligament. and it fuses with the orbital septum and inserts onto the inferior tarsal border on the lower lid. Uh, Tarsal plates, these are dense fibrous tissues which are mainly providing the structural integrity to the eyelids, and its length is about 29 mm, thickness is 1 mm, and the height of upper tarsus is about 10 to 11 mm, and the lower tarsus is 4 to 5 mm. And along this tarsus, you have the meibomian glands, which are about 35 to 40 in number in the upper lid and 20 in the lower lid. And this upper tarsus gives attachments to the septum orbital and the molars muscle, and the lower tarsus to the capsulopalpebral fascia and to the inferior palpebral ligament. Canthal tendons.
Just 1 minute. Go back. Yes. So, what is the clinical application of knowing the tarsal height?
Upper tarsus is much more than the lower tarsus, so
Correct.
you
So,
can use it for surgery.
how do we use it for
Graft.
surgery? Very good.
Graft.
So, how much? My next question would be, how much is minimum tarsus that is required to give support? So, tarsus basically gives support to your upper eyelid, and that is extremely important. If you don't have tarsal support, eyelid will go inside and it will cause an entropion, right? Because it is a posterior lamella. It is a rigid structure. So, how much minimum tarsus do you require in the upper eyelid? How much is minimum tarsus that you require in the upper eyelid? So, they say anywhere between 4 to 5 millimeters is minimum tarsus that is required in the upper eyelid to give stability. So, beyond that, whatever you have, you can use it for grafting or for lid reconstruction, depending upon the indication. So, that is something that you need to know. How much is the minimum anterior lamella that is required in the upper eyelid, Vignesh? 4. So, that is important because shortening of anterior lamella will cause ectropion. Shortening of posterior lamella will cause. Please proceed.
Canthal tendons, we have the medial canthal tendon and the lateral canthal tendon. Medial canthal tendon, they are the continuation of the tarsal plates
I think this we already covered. So you can just, I hope this is clear with everybody. The medial canthal tendon is basically like an XYZ axis. Okay, and I think we already discussed the clinical application for this. Lateral canthal tendon. It has superior and lateral cross called the limbs, and that also we already discussed. Okay, one thing. Okay, yeah, you're going to talk about it. Tell.
Okay. It has the superior and the inferior limbs. And in case of the retrobulbar hemorrhages, lateral canthotomy procedure, which is one of the site-saving procedure, can be done. And the incision is made mainly along the inferior limb, or it can be done on either on both the limbs also.
But why only retrobulbar hemorrhage? What happens in retrobulbar hemorrhage?
Increase in the compartment syndrome develops.
So it is compartment syndrome. What happens? So it is vision threatening. Okay, it is one of those few ocular emergencies in oculoplasty. Okay, if you feel there's increased retroorbital pressure, if there is an RBH or any condition basically which is causing increased orbital pressure and compartment syndrome, you can immediately do a lateral canthotomy canthalisis in the emergency itself. So what is that incision called, and how do you assess that you've already disinserted the lateral canthal, inferior limb? Anyone? So what is it called? It is swinging. Okay, when you extend it, it is called as a swinging T incision, but when it is just swinging, you know that it has given way, right? Okay. So you can call oculoplasty SR to do this if you guys are posted in emergency.
Then conjunctiva, they are the translucent mucous membrane made of the non-keratinized stratified squamous epithelium. And the parts of conjunctiva, you have the palpebral conjunctiva, which is further divided into marginal, tarsal, and orbital, and bulbar conjunctiva divided into scleral and the limbal. And then you have the conjunctival, which is divided into superior, inferior, lateral, and medial. Layers of conjunctiva comprise of 3 layers: the epithelium, adenoid, and the fibrous layer. The adenoid and the fibrous layer are together called as the substantia propria. So the epithelium, the marginal epithelium is made of 5 layers of non-keratinized stratified squamous epithelium, whereas the tarsal part is made up of stratified cuboidal epithelium. Fornix and the bulbar is made up of 3 layers of the stratified squamous, and the limbal is made up of 10 layers of the stratified squamous epithelium. And adenoid layer, this predominantly consists of the T lymphocytes. And this,
I think we can skip. This will come in your ocular surface. But what is the importance? What are we trying to convey by talking about this conjunctiva? What is an important part of the conjunctiva? Okay, go back.
Yes.
So yeah, how are eyelids and conjunctiva related to each other? Superior temporally, what is there in at the junction of the bulbar and the palpebral conjunctiva? So you have the lacrimal gland ductules. So if you have any cicatricial conditions, you have any chemical injuries, and if you have any scarring in the superior temporal fornix, okay, you will eventually end up with dry eye. Also, any surgery that you do, you need to know that you need to avoid that area. Okay, superior temporal fornix. Also, very important is your goblet cells. Okay, that helps in formation of what layer of the tear film? Yes. So any injury when you're taking any incision for any orbital approaches to, I mean, any transconjunctival incision or something, you need to be very careful of where exactly you're giving your incision and how you're dissecting the conjunctiva. Okay, that's all. And one more thing is when you have conjunctiviculosis with the blink, it is going to worsen. Okay, so that is another thing that you must look for when patients come to you with epiphora. What is conjunctiviculosis, Surabhi? What is dermatochalasis?
There is excess upper lid skin laxity, which occurs with the age.
Correct. So that is so conjunctiviculosis is excess conjunctiva, which is there.
Yeah.
And that you will see like an excess line in the lower lid, along the lower lid, or in the upper eyelid. Okay, so that is something that you must look for because that can cause that can cause foreign body sensation, epiphora. I'm just saying because that is related to the eyelid, and you must look for that as well.
Okay. Glands of the eyelids. You have the meibomian glands, glands of Zeiss, glands of Mole, and then you have the axillary lacrimal glands of Wolfring and Cross.
Okay, we don't need to go so much in detail. Tell me what is this right picture that she's shown?
Meibogram.
Yes, but it is meibography. Okay, right, excellent. So tell me one, okay, blockage of meibomian glands can cause what? Excellent, very good. So that is the only thing that we need to know here. Okay, it can cause meibomian gland disorder, which has severe gradings. I mean, 1, 2, 3. And if it is blocked for a long time, it can get inflamed and it can cause hordeolum and it can cause a chalazion in the long term. Chalazion is non-infective. It is a lipogranulomatous infection of the meibomian gland, and the treatment for that is conservative, 5-FU, triamcinolone acetate, or INC. That's it. Next. Next picture. Next picture. Yes. Okay. Yeah. So this is chalazion, basically in brief. Next. Wait. Now tell me, what is this right picture and what is the left picture? Which is right according to you? Which is left according to you? Wo batao. Okay. Why is it cyst of Zeiss and why is that cyst of Mole? What kind of a gland is the gland of Zeiss? Sebaceous gland will have sebum, which is there, which will be opaque. That is why it looks like whitish in color. So that is cyst of Zeiss. Okay. And cyst of Mole basically is transeliminant. Okay. And the test that we are doing is the transelimination test. Is everybody clear between these two differences? Very good. Next time, if you see a patient, you write incorrectly, no?
Arterial supply. Here, eyelids are supplied by the medial and the lateral palpebral arteries. Medial palpebral artery is a branch of dorsal nasal, and lateral palpebral is from lacrimal arteries.
I think so much detail is not required. Two things. What is the most important thing? Why do you need to know the arterial supply here? What do you do commonly in JCOC? So you should know the location of the vessels around the eyelids. When you are operating, you should know the medial and lateral palpebral arcades because that is the one that is going to bleed a lot. Okay. And yes, you should know about infraorbital vessels and supraorbital vessels and what is it a branch of. Because in case you go and inject a drug into one of these, what can happen?
Systemic.
Hmm?
It enters into the systemic
Correct.
circulation.
So from there, where can it go? You must have seen in JCOC in advent that is there. And angular artery also is very dangerous because when we are planning to give any fillers or anything in that area, where can it directly go land up? Ophthalmic artery. So it can cause actually a retrograde flow and CRAO also. So that is why anything in the inferior medial quadrant, you have to be very cautious while injecting in that area. Always aspirate. Okay, so that's the importance of this. Rest you guys can go and read. Next. Venous drainage. Okay, what is the most important two veins that you really need to know about? Why angular vein is important? So, where should your incision be placed? What is the surface anatomy of angular vein? So, it is somewhere between, technically, it is somewhere between 4 to 8 millimeters. That's why you place your incision either beyond 10 or a little more medially. Okay, so that is the rough estimate of the angular vein. It's okay even if you go in between, you can always cauterize it, but you should know how to identify it. Okay, and I think rest everything not too important. You guys can read this. There's nothing more important here.
Sensory nerve supply is by the ophthalmic and the maxillary division of the trigeminal, and the upper lid is supplied by the supraorbital, supratrochlear, and the lacrimal nerves, and the lower lid is by the infratrochlear and the infraorbital nerves. And the motor supply orbicularis is by branch of facial nerve, LPS by oculomotor, and Muller's is by the sympathetic nerves.
Okay, so wait, go back. Now let's say I want to do a lower lid surgery. Where are you going to block? What kind of block you will give if I want to do an extensive lower lid surgery?
Infraorbital.
So there is a difference between infiltration and there's a difference between block. What normally we do in oculoplasty is we give local infiltrations. We don't always give a block. What we do give a block for is many a times DCR, okay? Or if you want to do an extensive one part of the eyelid surgery. If you want to do a lower lid surgery, you give infraorbital anesthesia. So you block at the level of the inferior orbital foramen where your infraorbital vessels come out from. So that is generally you palpate the inferior orbital rim, go down 1 to 2 millimeters, okay, right straight along your medial limbus, which is there, and that is where you find and you directly give the injection. You have to ask the patient whether he's feeling any anesthesia, or if it's under local anesthesia, you obviously ask the patient any altered sensation along the nose and the upper lip. Okay, that is one thing. If you want to do an upper eyelid surgery, besides giving infiltration, you also block the supraorbital vessels, which is very easy and which is what you guys do day in and day out in your JCOC. But you just go a little deep into the orbit. Here you have to be a little more superficial. Identify the supraorbital notch or the supraorbital foramen and give the block there. Now for DCR, what are the blocks that you give for DCR? You give infraorbital block, you give infratrochlear block, and you give lateral dorsal block, of course along with local infiltration. This is important because if any one of us ask you to block, you should know what are the nerve supplies of the orbit. Okay, we don't give a lacrimal block ever, so that I don't know about. Thank you. Next.
Lymphatic drainage.
Wait. Sorry, one more thing I wanted to just respond. So there's something that we give a frontal nerve block also. Okay. When you want to do ptosis surgery, you can do a. Where is your oculomotor nerve here? Superior division. It is right in the center, okay, of the eyelid. So we give a frontal block when you want to do a ptosis surgery many a times. That's all. Thank you. Next.
Lymphatic drainage. Medial group drains into the submandibular lymph nodes, and the lateral group into the preauricular and the deep cervical lymph nodes. So, swelling of lymph nodes can be a diagnostic sign in case of the eye infections like conjunctivitis, and also in case of paranoid oculoglandular syndromes. And this is eyelid lymphedema. This can be seen either congenitally or acquired. Congenitally due to aplasia or hypoplasia, and acquired due to any damage caused by surgeries, radiations, or trauma.
Wait, so what is the importance of lymphatic drainage? And none of you people see that. Directly you'll say ocular E. What is the most common condition that you see in emergency when you're posted in emergency?
Conjunctivitis.
And what happens when you miss conjunctivitis and it kind of progresses and not being treated? And then what will you do after that? You'll send to ocular E. Okay, so when you have a patient with conjunctivitis, please know the lymphatic drainage, because those are the nodes that you need to palpate, not just for that, but in case of any lid lesions, orbital lesions also, these are the lymphatic drainages which are there, and you need to palpate the nodes every time you're doing an orbit examination. Okay, so preauricular is basically for the lateral third, okay, of the lower lid and upper lid as well, whereas submandibular is the medial lid lesions, that is where it generally drains. Yeah, so that is about it. When you see a preauricular node with conjunctivitis, viral conjunctivitis, and with some edema, don't send to ocular E. Treat the patient with some anti-inflammatories, cold compresses. Okay. Anything else? I think she's covered mainly everything. You can see lymphedema. This is also important because when you're taking incision over the skin, you should know the drainage and you should not cut the lymphatics, because in post-operative period, this is how it will become. It will not heal. It will not resolve. So that is why we don't take infra-orbital incision. If you see there, actually that is a patient post-op. I don't know for what it's been operated, but you can see the incision which is there in the lower lid, there in the right side. That's all. Take proper incisions and you can save and prevent the patient from having lymphedema. Okay.
Yes.
Anything else? Next.
That's
I think
all.
the last slide.
Yes.
References are incorrect, but I think we talk about that a little later. The order of references is not right, but okay. Okay, to conclude, basically you have 4 eyelids or blephrons. Okay, upper eyelid, lower eyelid, left and right. You have anterior lamella, posterior lamella, and the middle lamella. Any problem in the anterior lamella will cause your ectropion, secretory changes. Posterior lamella will cause secretory entropion. Middle lamella is extremely important also because it consists of the LPS and it consists of the orbital septum. You never suture the orbital septum. If in trauma, in the emergency, you have an orbital fat prolapse, that means the septum is breached. Okay. Besides that, she's already covered the canthus, medial canthus, lateral canthus, and how we reconstruct that. Lateral canthus is 1 to 2 millimeters above the medial canthus. Lid malpositions we discussed a little bit. We discussed about eyelashes and distichiasis and trichiasis. We discussed also about lateral canthotomy cantholysis in case of any raised intraorbital pressure. And LPS, very important question for you guys. LPS and orbicularis muscle. Okay, yeah. So basically, you need to just disinsert the lateral, the inferior crust or the inferior tendon of the lateral canthal tendon, the inferior limb of the lateral canthal tendon. So once you disinsert it, it is attached to the periosteum. Periosteum is a fixed structure. Once you disinsert it, the lid will be loose. So it is called as a swinging lid incision kind of thing. So you'll feel that give way away and the lid will be lax. So right now, all of you can do one thing. Just try to push your lateral canthus medially. You will feel the tension which is there. The moment you cut one of the limbs, that one eyelid will become lax. Okay? Anything else?
No.
So canthotomy, basically, it's the same thing. Canthotomy is making an opening. Lysis is cutting it. So first, lateral canthus you incise, but there you're not cutting any of the crust. Any limb you're not cutting. Lateral canthotomy means you're just widening the lateral canthus. बस उतना ही कर रहे हो. The limbs are still intact. When you do a cantholysis, it's one of the limbs that you're cutting. Thank you, Varsha.